in Europe. I came back with COVID, so I'm still in a more fragile medical state than I've been. So if I'm not quite as energetic as I would like to be, those are some of my excuses. But I enjoy collaborating. I enjoy meeting neighbors. I've always really respected some of the work that's being done here at this medical center. And since Partho joined, some of the work that he's excited about and some of the new areas that dovetail nicely with some of our concepts, I hope will open possibilities for collaboration and communication in the future. So the idea for these kinds of exchanges is not that it's simply a single lecture, but it's an opportunity to get to know each other and to get to understand how we can work more closely together. So I'm going to give you what I hope will be an interesting discussion on aortic stenosis, especially coming from what someone with a fairly traditional background as a proceduralist. So I began at the NIH doing interventional cardiology. I worked with Kenny Kent in 1979. We were the third group that did balloon angioplasty when I was at the NIH. We were the second group to put in coronary stents in the late 1980s, and the first group to treat patients with drug-eluting stents. So I've been involved in more traditional interventional cardiology as a proceduralist for 3.5 decades. But I'm going to go a little bit beyond the cath lab and try to focus on some of the issues that really point to how a change in one area can really help to transform the way a field evolves, because I think differently now about how we manage disease states, and I'll try to share some of those ideas. These are some of my disclosures, all of my disclosures. I begin these lectures often by recognizing some of the people that I've had an opportunity to work with, and this is Alain Cribier. This is Alain Cribier, April 16th, 2002, 15 minutes after the first TAVR in a 55-year-old man who was in cardiogenic shock and was not a candidate for a surgical replacement of his heart valve, and was treated without transesophageal echocardiography or general anesthesia, had a bicuspid valve and left ventricular dysfunction with an ejection fraction of 10%. This is the first case that was done, and this was in Rouen, France. And we spoke on the phone because we had been working together on this new device concept of a transcatheter valve. And the first thing he said was, okay, we've done this proof of concept, what now? And that's a very interesting question, and I'll try to help answer that question. This was the next morning. In typical France fashion, they're drinking champagne in the ICU. And we reported this first case, and this was reported in CERT. And it was a fairly humble response. Basically, our conclusion was that non-surgical implantation of a prosthetic heart valve can be successfully achieved with immediate and midterm hemodynamic and clinical improvement. Our concept being that this was only going to be for the sickest of the sick patients that truly could not be surgical candidates, with no understanding that there would be any opportunity to generalize this to the more mainstream patients with aortic stenosis. So no one could have predicted that in the ensuing 15 or 20 years, there would be a rapid technology evolution, procedural refinements and simplification so that we could teach people how to do this procedure, an avalanche of clinical evidence. And that was one of my roles, to surround this procedure in the form of clinical trials to generate evidence to help us understand if this was going to make a meaningful difference. The concept of the heart valve team emerged from this and became not just a byproduct, but now is we think, a very meaningful vestige of how we manage patients with complex cardiovascular disease, all of which combine to result in a dramatic reduction in complications and improved clinical outcomes, so much so that there was a 30-fold reduction in major adverse events in the first 30 days over the course of the first decade. One of the things we did was to develop a series of clinical trials called the partner trials. And this was over 15 years. We enrolled more than 10,000 patients in 5 randomized trials, published more than 200 manuscripts and abstracts, 11 of which were in the New England Journal of Medicine and the Lancet. It took this level of academic throughput to be able to convince the clinical community that this procedure really did have validity and legitimacy as being an alternative to treat sick patients with aortic stenosis. But I truly believe that clinical science should parallel innovation and new technology, and we have to be creative enough to design clinical trials that will help us to understand what's right or wrong about our new therapies. These culminated in some of the low-risk studies that we published in 2019. In the beginning, we never thought we'd be treating low surgical risk patients with aortic stenosis, and certainly led to the significant growth of this procedure, as shown here, where you can see that there's a dramatic increase in the number of TAVR procedures, now about 100,000 per year in the United States, resulting in this whole specialty of structural heart disease, which by 2026 will involve more than 500,000 procedures a year if you go beyond just the aortic valve disease. So I'm going to try to give you some understanding of not just this one technique, TAVR, but to talk about aortic stenosis as being a disease state and as a lifelong journey, emphasizing some of the issues relating to upstream, what we call upstream conceptual framework, to convince you that AS is both underdiagnosed and undertreated, to introduce the concept of preemptive or earlier AVR, and then to touch on some downstream considerations. I'm sure you're all familiar with this manuscript. This is one of the legendary manuscripts in all of medicine. This is the Ross-Brownwald circulation manuscript describing the natural history of aortic stenosis. And they almost got it right. This was the figure that is really branded in everyone's mind. It's probably the most famous figure in all of cardiology, suggesting that there was a long latent period, and then with the onset of severe symptoms, that it would be like falling off a cliff, and that unless there was rapid treatment, there was rapid demise. Now, after that was published more than 50 years ago, the only thing that really changed in terms of clinical cardiology reflections on this was that we extended the age out, because these were initially rheumatics and bicuspids, and now it's mainly more senile, calcific, degenerative aortic stenosis, but the concept was thought to be the same. We felt, unfortunately, that there were two fundamental fallacies, and have felt this now for quite some time, but we're not brave enough to, or bold enough to suggest it. First, that this latent period, that there were no important reversible or irreversible structural changes which could negatively impact subsequent clinical outcomes. We didn't think the latent period was in any way benign. And second, that the onset of symptoms is discrete, easily identifiable, especially in the elderly, and is inexorably linked to hemodynamic valve severity. So these fundamental fallacies became, for us, an obsession over the following decade. Involved in a Heart Valve Society meeting it's about 5 years ago, with Gene Brownwald. This was celebrating the 50th anniversary of that manuscript that he co-authored with a lot of people that are influential in the field. Bob Bono, who is one of my mentors, and Alain Cribier, of course. And we asked Gene Brownwald, from his perspective, what is one of the most important areas of clinical research that he's seen in the field of aortic stenosis. And he immediately pointed to a manuscript that we had published a year before. First author is Philippe Genereux, who works, as you know, in New Jersey, and was one of our fellows at Columbia. And it was to try to look at aortic stenosis from a different standpoint, and to try to develop a staging classification based on what we called at that time the extent of cardiac damage. It was shocking to us when you look at a large group of patients that were treated either with surgical AVR or TAVR. This is 1,600 patients. If you divide them up into various largely echo-derived stages, that by the time they had their procedure, already 85% had more than class 2 evidence of cardiac damage. And if you looked at the one-year mortality after successful AVR, it was striking to see that based upon the antecedent degree of cardiac damage, that predicted the one-year outcome. If you had no damage, it was less than 5% mortality. If you had significant damage involving the right heart as well, it was 25%. This was a very interesting observation. Then we began to look at patients after they had successful AVR and follow them over time. And it was fascinating to us that with baseline cardiac damage of stage 2 or greater, despite successful AVR, more than half the patients had either no change or worse cardiac damage at 1 year. And the impact of 1-year changes in cardiac damage on the subsequent clinical course, 2-year death and heart failure hospitalization, really was dependent upon whether or not cardiac damage as defined by these fairly simplistic echo parameters improved, didn't change, or worsened. So this created a hypothesis in our mind, which is that in severe symptomatic AS, waiting for symptoms as the main trigger for AVR resulted in accumulating and more cardiac damage, which is not reversible in most patients after successful AVR and predicts long-term adverse clinical outcomes. This for us became some of the guiding principles that drove a whole series of clinical investigations after that. Commenting with some of those observations, many other data sets became available. One that has been well known is the data out of Australia, looking at a national echo database suggesting that patients with moderate aortic stenosis had pretty much about the same mortality as those with aortic stenosis. So we did the same thing. We took some of our colleagues, Jerome Bax and his group, Victoria Delgado and others, from University of Leiden, who have a wonderful longitudinal database. And we looked at all patients with moderate aortic stenosis applying the same principles, over 1,200 patients. And what we found was that in those patients with moderate aortic stenosis, largely asymptomatic, 60% already had evidence of significant greater than stage 2 cardiac damage. And if you look at their 5-year mortality or mortality, stroke, or rehospitalization, again, the degree to which you had cardiac damage predicted late clinical outcomes. So it wasn't just the severe symptomatic AS patients. And this caused us to believe that aortic stenosis is largely misunderstood. We focus on what happens on the left, to the hemodynamics and the morphology and the anatomy of the heart valve. And we think treatment dogma, which reflects whether or not a valve area is less than a certain amount or capacity is beyond a certain amount, really has become the treatment. But these are two parallel processes, unfortunately, with some degree of variable linkage. And if we look at the adverse events that occur as a result of aortic stenosis, mortality, symptoms, cardiac damage, you can draw a family of curves. And it's very difficult to predict at what AS severity that the adverse events occur. So there's wide patient variability in what we call AS pressure load tolerance and the expression of adverse events. So this led to a conceptual framework of how we think about the disease, not only in the traditional aspect, but as a chronic disease. And that is for both bicuspid and senile calcific forms. It's punctuated by various clinical events, atrial fibrillation, cardiac symptoms, and structural changes. We've discussed some, LVH, pulmonary hypertension, right heart failure. But earlier management, both diagnosis and treatment, coupled with meticulous follow-up, we believe leads to optimal clinical outcomes. We still have to prove that. And that delaying the progression of calcific AS before the onset of symptoms or the need for AVR should be an aspirational goals and is one of the goals that we're now beginning to address. And the clinical research effort should shift from late stage reactive AVR to early stage preemptive AVR and other complementary therapy approaches. And it's with the availability of a less invasive, low-risk transcatheter technology combined hopefully in the future with more durable heart valves, something we're working on, coupled to enhance easily accessible early diagnosis that will truly transform AS patient management paradigms in the future. So AS is a lifelong journey, and I have spent most of my career focusing on the index procedure. How do we make it easier? Minimalist. How do we enhance the technology? How do we expand the indications with new clinical trials? Respecting patient preferences. But I think very important is that we think upstream, improve diagnosis, and we'll talk a little bit about that, access to care, preemptive treatment, and pharmacotherapy that's going to delay the onset of calcific aortic valve disease, and that almost nobody thinks downstream. And downstream, we've got to deal with bioprosthetic valve durability, the concept of therapy sequencing, particularly in younger people, the issue of concomitant cardiovascular disease, which is ubiquitous, by the way, in these patients, and other adjunctive pharmacotherapy that can treat and condition the already sensitized left ventricle. So let me move on to this issue of underdiagnosis and undertreatment. We became, a group of us became interested in the epidemiology of valvular heart disease and understanding a better approach to appreciating the prevalence of aortic valve disease. And frankly, very few of these studies have been done. Most of them have been done in Minnesota, and they apply to a population of patients that live in Olmsted County. And if you think the prevalence of aortic stenosis is really based upon those studies and reflects the rest of the country, you're wrong. So we spent a lot of effort to develop what we thought would be a modern era diagnostic epidemiologic study. David Cohn, one of my close colleagues, spent 9 months developing this protocol. And I'll give you a sense as to what we tried to incorporate. First, we used our Cardiovascular Research Foundation for data coordination to help with study design, the Echo Core Lab, and as a data repository. We worked with the University of Michigan Survey Research Center because they're the experts in sampling strategy and population weighting. They do it for politics, they do it for medicine. They can tell us if we have the right 5,000 patients enrolled in this study, it will accurately predict the prevalence of disease throughout the United States. We worked with Vanderbilt University in their biobank because we felt it was very important to have opportunity to look at things beyond just the imaging and the clinical phenotypes. We have we'll go into this a little bit, a deep learning environment at Columbia, and we've been working on some algorithms to detect AS from ECGs. So we apply this as well. And then we got a group called the Hawthorne Effect that would go into people's homes and would acquire the data, because we felt unless we had quality data, we would not be able to really accurately interpret some of the findings. And finally, how do we find these people? From CVS. They have a healthcare environment, actually, and they helped us to enroll people who had no known heart disease who were more than 65 years old. Now, we've enrolled about 3,000 of the 5,000 patients that we had planned to enroll in this study. But I think a study like this is going to give us a better understanding of what is the true prevalence of not just aortic stenosis, but other valvular heart disease conditions. And if you're going to be able, and if you're talking about treating patient populations, you have to start with understanding more about the disease. Now, the issue of diagnosis has been a fascinating area. And speaking with Partha, it's fascinating that we've had some parallel experiences. This is one of the early manuscripts out of the Mayo Clinic, and Peter Noseworthy and his group, J.O. and others, have been involved in this, looking at the ECG as a screening tool for stenosis using artificial intelligence models and algorithms. We have been doing a few years behind, but now is accelerated into a 17-person group at Columbia and New York Presbyterian Hospital, which is led by Pierre Elias, who's one of our early career faculty, who spent many years in industry looking at artificial intelligence to look at the ECG as an analysis method for detecting left-sided valvular heart disease. This is a lot of work, and you can imagine. We've now looked at 12 million ECGs, 1.5 million echocardiograms from 8 hospitals. The data has been sanitized, tokenized, validated, and harmonized, and it involves the entire Columbia community. And we demonstrated, I think, that using various models that machine learning can detect with very reasonable sensitivity and specificity certain forms of valvular heart disease. Now, we felt that wasn't really enough. What we wanted was a prediction score that would encompass clinical factors in structural heart disease that would cause a physician to take note. Certainly a reduced ejection fraction, certainly patients that have LVH, valvular heart disease, pulmonary hypertension, RV dysfunction, pericardial effusion. So we created a model that would allow us to have a prediction score, and using that prediction score to identify people who might have a high frequency or a high likelihood of having structural heart disease. And you can see on the far right, as we tested this prediction score model in 85,000 patients, that we found that about 9% had a high prediction risk for structural heart disease, of which about half went on to get an echocardiogram just as part of their clinical course. And we demonstrated that the positive predictive value of the ECG in diagnosing significant structural heart disease was 74%. So we're beginning to now start thinking of how we can use these techniques to be able to affect healthcare. And this is a study that just began last month, and it's now been rolled out into 6 emergency departments at New York Presbyterian Hospital. And this would have every ECG that is obtained in the emergency department is flagged as high risk using these prediction models. And when that occurs, we attempt to get an echocardiogram, and we have various ways where the echocardiogram is obtained using a research nurse care coordinator and in communication with referring physicians to try to get a better understanding of whether or not usual care is being modified. So we think that ultimately these relatively straightforward models that can apply to common tests can be a much more effective screening tool to better understand whether or not patients need higher level imaging, such as echocardiography. Now, there are so many other ways that machine learning can be used, and Partho has published what I think is a seminal manuscript, which really looked at machine learning to identify phenotypes of aortic stenosis severity so that you could profile these patients and make priority decisions about who needed to be treated earliest. So these kinds of approaches to machine learning, I think, will have an important impact on how we manage patients. We also work with large databases. This is the Optum database, 80 million people. And much to our chagrin, we published this a few years ago, that over 60% of diagnosed severe symptomatic AS patients in this country were untreated a year after confirmed diagnosis. And what were some of the associated factors? Certainly, Black patients were less likely to be treated. If you were a woman, you were less likely to be treated. And depending upon the managing cardiologist was the greatest single factor as to whether or not a patient would be referred for more advanced treatment consideration. So we're learning a lot about the way disease is being accessed, the way diagnoses are being made, and the way those diagnoses are being managed from the standpoint of treatment. Another recent manuscript demonstrating clearly that racial, ethnic, and socioeconomic disparities also affect the utilization of aortic valve replacement. And an even more recent manuscript looking at the 2 Harvard hospitals over an 18-year period, indicating that more than half of these patients that were screened had an indication or potential indication for AVR, but less than half actually received AVR within 2 years of diagnosis. This is at the Mass General and the Brigham and Women's Hospital. And it varied depending upon the subtype of disease. Those patients with high gradient normal EF were more likely to be treated. But if you had low gradient and normal or low EF, more than half of these patients were not being treated. So we've been working with the AHA on a concept called Target AS. AHA has done a remarkable job with stemming and get with the guidelines to be able to reduce time to treatment in patients with acute MI. They're trying to do the same thing with aortic stenosis, to collapse the awareness, detection, diagnosis, referral, and treatment into what is a circumscribed mechanism that will allow hospital systems to improve their treatment methods, with a 90-day call to arms from echo diagnosis to AVR for aortic stenosis. This the pilot has been up for 2 years, and you'll certainly be hearing about this in the future. Now, this leads to some of the concepts that we've been discussing, such as preemptive AVR. Now, this is not new. There have been 2 surgical series indicating that early surgery versus conservative care for asymptomatic severe aortic stenosis might have some advantages. This is a small study. It's less than 150 patients. It comes out of South Korea. It's younger patients. It may not be applicable to all the patients you see. It certainly suggested that there was a significant benefit associated with earlier surgery. And a confirmatory study, again, a small study, 157 patients, that comes out of Europe, the AVATAR trial that just finished 5-year follow-up, showed the same thing, that early surgery versus conservative treatment may have some real benefits. So this caused us about 8 years ago to come up with the idea of doing a TAVR, asymptomatic severe aortic stenosis study. And this is called the early TAVR trial. And ultimately, we enrolled almost 1,000 patients that had exercise test confirmed asymptomatic severe aortic stenosis that were randomized to usual care, which is clinical surveillance versus transfemoral TAVR, and then follow them with an endpoint at 2 years of all-cause death, or stroke, and unplanned cardiovascular hospitalization. It was a superiority design. As I said, we enrolled over 900 patients. And this will be presented at TCT this year. We're just beginning to unblind the data now. We'll do 10-year follow-up. But this has the opportunity to potentially change the way we manage severe aortic stenosis, recognizing that for every symptomatic patient, there's an asymptomatic patient with severe aortic stenosis. Now, it's not the only study of this kind. There are actually 4 severe asymptomatic aortic stenosis studies. But another one that I really like is the EVOLVE trial coming out of the UK. This is David Newby and Mark Dweck. And this is just under 300 patients of at-risk asymptomatic severe AS patients that were screened based upon biomarkers and then cardiac MR looking at mid-wall inhibition, suggesting that there was early fibrosis, and then randomizing early intervention, either surgery or TAVR, versus routine care. This will also be presented at TCT this year. So you'll have 2 very important studies in asymptomatic severe aortic stenosis telling us if the preemptive or earlier treatment, rather than that symptom trigger point, is going to make a difference. Now, severe aortic stenosis is one entity, but I just suggested to you a few moments ago that moderate aortic stenosis also does not have a great prognosis. And if you look at these event curves looking at cumulative survival over time from that Australian study, you can see that the bottom 2, which is moderate and severe, are not very different. So we've really gone very aggressive in terms of trying to understand if in moderate aortic stenosis there are treatment subsets that would benefit from earlier aortic valve replacement. This is some of the early work that we did with Nick Van Meegen in the Netherlands, who was very interested in this topic, looking at patients that had HFrEF, reduced ejection fraction, and moderate AS, with and without intervention, and then comparing it just for a non-valvular heart disease, heart failure, reduced ejection fraction population. If you have moderate AS and a reduced ejection fraction, and you are not intervened, you have a 5-year mortality of 80%. That is cut in half if you do intervention. Now, this is not a randomized trial. These are various subsets, but it certainly did provoke a lot of interest. And it caused us to do another study called TAVR Unload, which is to take patients with moderate AS, reduced ejection fraction, and heart failure symptoms, and to randomize them to either TAVR plus optimal heart failure therapy versus heart failure therapy alone. and then to see what the outcomes are. This is a smaller study. It's about 180 patients, a very interesting clinical trial, a very event-rich trial that's completed its enrollment from 47 sites in the US and Europe, that will also be presented at TCT this year to give us an understanding if moderate AS in an at-risk low ejection fraction population could benefit from earlier treatment. This concept of upstream management or preemptive treatment in moderate AS has really taken off. These are just some manuscripts talking about specific at-risk predictors in the moderate AS population, and they include moderate AS patients with symptoms. We mentioned low ejection fraction, atrial fibrillation, low stroke volume, diastolic dysfunction, evidence of rapid AS progression, elevated cardiobiomarkers, and elevated calcium scores. We use this to develop another clinical trial called the PROGRESS trial, a large study in moderate aortic stenosis with either symptoms or cardiac damage that would be randomized to early TAVR versus, again, clinical surveillance with a primary endpoint similar to early TAVR at 2 years, and we've already enrolled this trial. So we are going to have, in a relatively short period of time, a lot more data about other AS populations that could benefit from earlier intervention. And the EXPAND TAVR 2 trial is a similar trial that's being done with the self-expanding TAVR system. The PROGRESS trial was done with the balloon expandable system. So one of the ways to look at this is, as an oncologist looks at tumors, you grade them and then you stage them. Well, grade the hemodynamic severity fairly well using echocardiography. I would argue, and I'm sure Partha would agree, that that may not be the best way to grade disease severity, but we also stage it now. And we have, those green boxes are guideline-directed AVR treatments. I'm hoping that with these trials, we're going to fill in a lot of these yellow boxes. And then I think in the future, we're going to be working in that red zone. And that's where we get to this downstream consideration as well. I would think that after you've managed these patients and you've been able to achieve a successful initial clinical result, you return them to their care environment. That's probably not the smartest approach. And we now think that the downstream management of patients that have been treated is an essential component of managing a disease state. We have to worry about aortic valve durability. We have to think about, as we mentioned, therapy sequencing. And let's get into a few of these things and explain why it's so important. This is an interesting research letter that was published last year in JACC, looking at TAVR and SAVR procedures, surgery and TAVR, by age group in the US, and focus just on the less than 65-year-old age group. And what you will see is that about half the patients under the age of 65 are now getting TAVR. We have almost no data in young people who are treated with TAVR. But that is a dramatic recent trend that we have to address. And it really speaks to the issue of, if we're going to treat young patients, then the issue of bioprosthetic valve durability really needs to be confronted aggressively. We've worked hard to develop some of the standardized definitions for bioprosthetic valve dysfunction, and we won't bore you with the details. And there is some data, certainly in small groups, out to 5 years, 5 to 8 years, suggesting that either structural valve deterioration or bioprosthetic valve failure, out to 6 to 8 years, but these are small numbers, looks to be fairly reasonable. But this is only the tip of the iceberg. There's much more that needs to be done. We've now applied some of these definitions in some of our clinical trials, and it confirms the fact that there seems to be not much difference between TAVR versus surgery, looking at 5-year careful analyses, both with the balloon expandable and with a self-expanding device. And these are some of the data that came out of the low-risk trial, again showing that there was not much difference between surgery and TAVR if you look at 5 years at bioprosthetic valve failure or structural valve deterioration, which is encouraging. But many surgical valves fail between 5 and 10 years. So we have to follow these patients out to at least a decade. But I will tell you that there's no question that you're going to be seeing more of this, which are failed, either balloon expandable or self-expanding TAVR valves that will end up being surgically explanted or treated in other ways. So in the future, new bioprosthetic valve platforms need to be introduced and tested that hopefully will have improved durability profiles. If we look now at bioprosthetic valve failure in what is a large national registry, the TVT registry, it's dominated by surgical valve failure in red, and those blue boxes are the TAVR patients that have begun to develop dysfunction. But that's out to 2021. If you follow these curves, and we've done a lot of very aggressive modeling and a publication which has just been released, that by 2028, the number of patients that have failed transcatheter valves will exceed the number of failed surgical valves. And this will have an important impact on how we manage patients, particularly younger patients going forward. A lot of this is about the leaflets and material science innovation. There are several versions of new things being developed that may be exciting for the future. There's a version of the Edwards bovine pericardial valve called Resilia that has stable aldehyde capping and uses glycerol rather than formaldehyde for and glycerolized tissue allows you to have dry leaflet storage that may affect, and in some of the early surgical data, may improve durability. Now that's been incorporated in multiple of the platforms of Edwards valves, but there are many other things that are being developed. This is one that you should be aware of. It's been developed by a company called Anteris, and it's called the Dur-AVR concept. So it's a single piece of pericardial tissue that's been shaped on a mandrel using a balloon expandable platform. But what's fascinating about this is that when you look at the hemodynamic results, they're extraordinary, well beyond anything we've ever seen with a balloon expandable or even a self-expanding valve. This may have some implications in terms of durability. And then going one step further, we've been working intensively for the past 5 years with a company called Foldax that have developed polymer valves. And this is a siloxane polyurethane derivative that's been used in pacemakers for years. And it's now been used in surgical valves. We reported the first data from a surgical mitral series from India just 3 days ago, and it will be used in transcatheter valves as well. And what's particularly interesting is that this is made using robotic engineering. So there's no hand sewing of leaflets. And this polymer leaflet material is essentially indestructible. So the hope is at some point, maybe we will have durable valves where one valve for life will be what we can offer patients. And finally, I don't want to lose sight of the fact that we incompletely understand the pathophysiology of aortic stenosis. We have a concept in mind, and it's always easy to put a concept on a page, as you see here. But in valve leaflets, you see endothelial injury, lipid infiltration, inflammation, much like atherosclerosis. That ultimately those pro-inflammatory mediators evoke micro and then macro calcification. At the same time, you're getting myocardial remodeling, and this is the sequence of events that occurs in aortic stenosis. But I will tell you that as of today, there are no known proven medical therapies to slow or prevent the progression of calcific aortic valve disease. But there's going to be, in the next 5 to 10 years, a dramatic change in terms of the effort to try to see to what extent we can alter that phenomenon. This is an article that Brian Lindman wrote, trying to understand why the pathway to developing pharmacotherapy to prevent aortic stenosis has stagnated. I will tell you there are a host of new targets that we're beginning to look at, like Lp(a) and PCSK9 and many, many other things. We've had difficulties with the clinical research pathway, but this is all changing. We're also realizing that the only target is not just the development of calcific AS, but the residual risk from heart failure due to cardiac remodeling and irreversible injury. Because after TAVR, almost 50% of patients, particularly high-risk patients, either have died or have residual heart failure with poor quality of life at 1 year. So it's really important to look at these patients, not just at the procedure and 1 month, but to follow them afterwards. And there are new models that are being developed to be able to see to what extent we can target medical therapy at the ventricle to protect the pressure overloaded heart while AS progresses, and to augment LV recovery after AVR using some standard medications. And there's a study we're going to be starting soon with SGLT2 inhibitors. But there's no question that in the non-responders, there may be some pharmacotherapy approaches that we can consider. And the clinical trial pathway needs to be dramatically changed. Adaptive randomization, real-time Bayesian analyses, using common control arms, imaging endpoints. A lot of different approaches to clinical trial methodology will be incorporated in some of these studies, much like what was done during the pandemic with COVID drugs. I think will start being applied to some of these new therapies that we're looking at to prevent and alter disease progression. So going back to that grading staging chart, we believe that multi-drug precision medical therapy at an earlier stage of disease, if we can identify the right patient responders, will be an approach early during the course of aortic stenosis, much like you treat hypertension. In addition to, obviously, as the data dictates, earlier and targets to be able to treat earlier some of the patients who develop more severe forms of aortic valve disease. And I'm going to go back to that, original figure of Alain Cribier, because unfortunately, Alain Cribier, February 16th, passed away. And he truly was a caring physician. He was a humble humanitarian, used to go to, in fact, Partha was telling me that he would visit hospitals that he was familiar with to bring his mitral valvulotome to treat patients. He was truly a creative iconoclast, was a gifted operator, and his two most endearing qualities were his passion and his perseverance, which led him to succeed in what many people called his crazy dream. And one of his favorite quotes was from Andre Gide. One doesn't discover new lands without consenting to lose sight of the shore for a very long time. And it took about 20 years from the original valvuloplasties he did in the 1980s to the reality of being able to develop a transcatheter valve that could be implanted on a beating heart in an awake patient as a form of therapy. So it never happens overnight. So what I would say to Alain when he originally discussed the outcome of his first case, okay, what now? What I've tried to communicate to you is that that is just the beginning, and that there's so much more to do. And I think that in his honor, it behooves us to look at this disease and the invention that he helped to create as an opportunity to be able to try to study aortic stenosis. And this will spill over to other valvular heart diseases and certainly other areas of structural heart disease, in ways that will improve diagnosis, target therapy more accurately, develop other concomitant treatments to manage non-responders, and really to have an influence not just on a procedure, but on a disease state over time. Thank you.
Thank you very much, Bobby. That was absolutely wonderful to get. I think you'll remember the start from this. I'd like to open the discussion and have invite people to comment. I wanted to ask a question to you. We have struggled to be precise in one subset of aortic stenosis. So we call them as disordered aortic stenosis. Clearly identified, it's very challenging because these numbers don't match. But I think the bigger disservice is looking at the left ventricle with fraction as a parameter, and we whole heart failure community hasn't fully. So how do we in develop screening criteria or convergence when without experts all being there, it's very difficult to cognitive insights out in the community. If you out into the community, what would be the next steps? And given that there's so much of ambiguity in that area.
You know, that's really a tough area. I mean, certainly ejection fraction is a very crude index. I think everybody appreciates that now. That's why this you know, LV strain, RV strain, LA strain, everybody's looking for other, what they believe to be more sensitive reflections of left ventricular function or certain characteristics of left ventricular function, and then incorporating that with both systolic and diastolic dysfunction. So I think the definition of left ventricular performance is going to continue to change. But I will say that there's so much more to that, because right now the acquisition of data, echo data, and the standardization of echoes in this country is absolutely horrible. The reading that is being done is largely descriptive and not analytic, which makes it even more complicated. So we're going to need to develop tools that help us to be able to identify certain disease patterns, and done in ways that the human eye is going to have a difficult time understanding, and that will enable humans to be able to make diagnoses that I think will be far more precise. And that's where the artificial intelligence and the machine learning, I think, is going to come in.
And the second comment, we have observed the echo has not worked. We are relying on calcium scores, calcium score, but calcium score in this model necessarily not any problem from that.
Very, very crude calcium scores. It's simply an eyeball test of, you know, whether or not you think significant aortic valve disease or not, but it's not discriminating enough to make individual case-based decisions. So we're going to have to go well beyond that too. I think cardiac imaging really is central. When everybody talks about aortic stenosis, we talk about the structuralists, we talk about the surgeons, but somewhere in between are the imagers. And to be honest, I think that the imaging explosion in valvular heart disease and structural heart disease is going to dominate our thinking over the next decade.
And I think we're not training enough people to be good measures.
We're not training them, and we're not, unfortunately, they're not being reimbursed for their efforts. So there's a lot of things that need to be changed in order to equalize them. Getting fascinating. There were two presentations in New York that looked at robotic transesophageal echocardiography. And we're working with one group from Hamburg. There's another group in California that are developing some interesting ways, because we don't have enough imagers that have enough training to be able to assist in these procedures. So we're trying to develop other compensatory approaches. And it'll be interesting to see how that evolves. So right now, we're going to slow down the introduction of the new tricuspid therapies simply because we do not have an infrastructure to train sites and to be able to make sure that the cases are properly covered so that they can get optimal outcomes. So you know, this is one instance where the technology is ahead of the clinical care environment and infrastructure to be able to utilize it.
Part by the variability. Population of other normally intervene?
It's not even when they're symptomatic. I mean, the problem is that many, especially if you're an older person or several other demographic subcategories, um, even if you have symptoms, people wait until they have more severe symptoms. So the general medical community and the cardiologic community needs a refresh in not just aortic, but in overall valvular heart disease. And I think that that's going to be coming over the next decade. Everyone's going to be investing huge resources. That's why this Target AS program is so important, because it is like get with the guidelines. I mean, who now wouldn't take a STEMI and take it to the cath lab quickly? If we could create that mentality, and if we can present data demonstrating how life-saving it is to make an accurate early diagnosis and prompt treatment, then I think it's going to force the entire medical community to adjust. But that's the hope.
Given that TAVR's been around for a minute now, TAVR and TAVR, and clinical trial starting, and where does your role for that?
Well, there are 3 studies being proposed now in bicuspid disease. On which side of the ocean? The lower end of the age spectrum is 50 or 65. And then there's another study being proposed that'll be proposed to the Cardiothoracic Surgery Network and the NIH, which is a young TAVR study, which is to treat people over the age of 50. Not to treat them, but to study it in a randomized fashion. These are difficult studies to do because obviously a lot of the issues relate not to the index procedure. The 1-year results are not going to make any difference, frankly. It's going to be the 5, 10, 15-year results, how you sequence procedures. So it's going to be much more complicated to do that. But there is going to certainly be an aggressive effort to try to study and understand what happens to younger people who have valvular heart disease and who are treated with AVR. Now, some of these new valve leaflet materials may make enough of a difference, stimulate some of this, but it's going to take a while. None of these are on the horizon.
My question is on patients who have mild aortic valve stenosis. I know you touched on it a little bit. Population. But if you diagnose and patients who have mild aortic stenosis, just to catch it sooner and maybe assess it, do you think we are diagnosing this too soon and getting people scared? Because there's even like vision. There's a long time period before they even here in the population. So just what your thoughts are.
I think that's a great point. I think that you can't treat every disease at the first onset sign, symptom, or morphologic feature of that disease. So you have to use some reason and judgment in all of this. The idea of how to manage the mild AS patients is that there may be drugs that we can suggest, much like, and I use the example of hypertension, that would delay the progression of calcific aortic stenosis. And that's where I would consider that if the data looks strong, that would be an interesting approach to younger patients who are asymptomatic that have mild aortic stenosis. But we would never suggest a procedure in somebody with mild AS who is asymptomatic. But in the severe AS patients, they don't do well untreated, whether they're symptomatic or asymptomatic. And the moderate AS patients, particularly if they have certain at-risk features, if they are not treated, they don't do as well. Now, when surgery was the only option, and you were dealing with an open thoracotomy, and you were dealing with the sequelae of that, and a prolonged hospitalization and recovery, but now we're dealing with a procedure that's going to have less than a 1%, 30-day significant clinical outcome risk, and that allows patients to leave the hospital the next day. So if you're in the categories of severe asymptomatic AS or moderate at-risk AS, I think you should be at least considered as a possible candidate for earlier treatment.
Mitral stenosis or mitral calcification and aortic stenosis. So there's a lot of these TAVR patients that I'm reading, cardiac CT scans and TAVR CTs and these, a lot of MAG. Now,
Yep.
some of these patients could have, severe mitral stenosis, but we tend to leave it alone and that there has been some studies in this area. But what are your thoughts on leaving that alone and just, chasing out the TAVR and millions of trials? And, we have an industry and it's all of this. So,
Well, trust us, we're chasing after everything. Right now, the first approval for a transcatheter mitral valve will be in the MAC population. So we're recognizing that MAC is not such an innocent bystander. And I would argue but the treatment has really been elusive. Surgery has been problematic and there have not been any transcatheter. So there may be some approaches to MAC that I think will allow us to get better results. But the MAC patients we're treating are symptomatic MAC, severe patients, not just an imaging observation, but an imaging observation attached to a clinical syndrome. But I think there will be approaches, and I think you'll see them commercially available probably in the next 2 years.
I have a quick question. On one hand, we're talking about more procedures, hopefully after the trials come out for moderate AS. On the other hand, we're also talking about sudden explosion of patients with failed TAVR, and we're going to have good solutions for those. Either surgical explant or having TAV because of the commission not alignment. And none of the valves that we have at this point. How do you solve that problem? What happens when you get so how do you balance?
Well, again, we're trying to address that. And I think that there's no answer to the question that as we get better and diagnose earlier and identify high-risk subsets, that it probably would suggest that more procedures in a broadening group of patients would be appropriate. But I would argue even now, some of the procedures that we do can be refined and adjusted. I think the issue with bicuspid aortic valve disease is a good example. There have been very few studies, and that's a very prevalent form of aortic stenosis. And I'm not sure that in all patients that TAVR is going to be the best solution for a variety of reasons. So I think we got to refine our decision making. We're going to change the way we structure healthcare delivery. And yes, more procedures can be done more efficiently in a variety of different environments as they need to be done. I think we can prioritize better. And Partho has some interesting ideas about using the imaging as ways to be able to decide which patients need to be treated earlier. So I don't think it's going to crash the healthcare system. I think it's going to help to treat patients that have this disease is no less malignant than some of the worst cancers that we see. And I can't imagine that you would, if you saw somebody with a pulmonary nodule or multiple pulmonary nodules in an asymptomatic patient, what would you do? So we're talking about a disease that untreated moderate aortic stenosis has a 5-year mortality of 30%. So what I'm suggesting is we'll find ways to adjust the medical system to manage what might be an influx of new procedures. But I think we all have to learn together, and I think that's where healthcare delivery is so interesting and challenging.
Marty, you made a very important point that the cardiac damage and the residual damage that remains after the procedure means that we need more heart failure specialists. And we have a big problem in which our trainees, because there are a lot of specialists here, trainees and who are wanting to go into the specialties. So how do we train and get people to go into heart failure as a specialty? Because here there's a big gap that we see.
It's massive. We're trying to work that through in multiple. I think it's difficult. I think that heart failure physicians, I'm very sympathetic. We have a very, very large heart failure program. We have a faculty of 30 at Columbia in our heart failure division. And it's a big outpatient problem. It's also a big inpatient problem. 70% of the CCU admissions are largely heart failure related. So I think that, it's something that we're going to have to learn to overcome. One of the things we are doing is we're using very effectively physician extenders in ways that you can really take the heart failure physician and make that physician at the center of a working group that could manage a much larger volume of patients using new tools. So we're using, if it's not CardioMEMS, it's wearables or other things to be able to earlier on make a better diagnosis and treatment adjustment. So I think that there are going to be ways of managing it, but it's not going to be the conventional way, one doctor for each patient. It's going to be done in a much more creative healthcare provider mode, at least I think.
Now, I wanted to just end a note of optimism. So we're going to look forward to working on this challenge together, and I'm
Yes.
going to look forward to creating collaborations in health systems. This is an enormous opportunity beyond the clinical trials that are currently coming in. To also expand on the opportunities on non-invasive ECG, AI, and there's so many other opportunities. Really thank Marty for your visit here and for inspiring us to remain optimistic about the future of.
You have great expertise here and tremendous potential, Partho. And one of my closest friends in past generation was Don Bain, who was one of the early leaders in interventional cardiology. He had this concept of the zone of repugnance. And the zone of repugnance was that you would never refer a patient if you were less than 50 miles away. Well, we're pretty much beyond the zone of repugnance. And I think we can collaborate actively in all kinds of things. And you're going to have the kind of expertise that certainly can be taken advantage of as we develop new clinical trials and we try to better understand disease concepts and therapy approaches. And I'm hoping this is just the beginning.
Thank you very much.